Let's welcome our next speaker, Dr. Nanako Iwami from Kamiya Ladies Clinic. Dr. Iwami, she graduated from Sapporo Medical University Hospital and then obtained MD in Sapporo Medical University. Right? And she did her internship in Sapporo Medical University Hospital. And then she worked in Itabashi Chuo Hospital. Then also became a fellow in Sapporo Medical University Hospital again, and also for another 2 years in Tomakomai Ladies Clinic. And from 2014, she started working in Kamiya Ladies Clinic. So today, the presentation is going to be efficacy of endometrial microbiome metagenomic analysis, EMA, and analysis of infectious chronic endometritis, which is ALICE, on in vitro fertilization outcome in women with recurrent implantation failure. Okay, let's welcome Dr. Iwami. Dr. Iwami, please.
Thank you for giving me this opportunity to this presentation. Today, I will talk efficacy of EMA and ALICE in women with recurrent implantation failure. Multiple factors are associated with implantation and continued pregnancy, but it is well known that the biggest factor is the chromosomal factor of the embryo, however, even when euplod embryo are transferred, many reports suggest a pregnancy rate of 60 to 70%, with the remaining 30 to 40% being related to factors other than the embryonic chromosome. Factors other than the embryo include immunity, implantation window, and the intrauterine environment. It is impossible to identify all the factors that contribute to inability to get pregnant, but with the advancement of medical science, new tests are becoming available, and the causes of unexplained infertility are becoming better understood. In this presentation, we will focus on the intrauterine environment and explain the effectiveness of the test and its treatment. Several reports said that lactobacillus could maintain pregnancy through a variety of actions. The main ones are the 4 functions shown here. Lactobacillus controls adhesion and competitive exclusion and autophagy through the production of H2O2, bacteriocin, and birth surfactants. It also contributes to production of various immune-related substances, such as IgG and IgA, and these functions prevent the entry of bacteria from the outside of environment. Especially in the uterus, when other bacteria colonies grow and cause chronic inflammation, cytotoxic immune responses become dominant and may attack the fertile embryo as a host. In other words, lactobacillus is thought that the uterus may prevent external invasion of bacteria and support the implantation environment from an immune as well. The endometrial cavity has traditionally been considered a sterile cavity because the endometrium contains 4 orders of magnitude fewer bacteria than the vagina does. Recently, using NGS allowed for the detection of both culturable and non-culturable bacteria. Chronic endometritis is persistent endometrial inflammation mainly caused by bacterial infections. Chronic endometritis is found in about 30% of infertile women and 60% of patients with race. So, it is important to detect the pathogenic bacteria cause chronic endometritis. The microbiota profile in the endometrium fluid can be classified as lactobacillus dominated or non-lactobacillus dominated with a cut of 90% lactobacillus. Lactobacillus dominated microbiota in the endometrium was reported to be associated with favorable reproductive outcomes. In 2016, Moreno reported that implantation rate and the delivery rate was significantly higher in groups with more than 90% lactobacillus in the endometrium cavity than in groups with less than 90% of lactobacillus. This indicates that the more lactobacillus-dominated uterine environment may make the higher the pregnancy outcomes. Are endometrial and vaginal microbiota the same in all patients? Although lactobacillus is generally considered to be more common in vagina, the same paper also reported on whether the biological balance between vaginal and endometrial microbiota is consistent with each other. This report showed that some bacteria present in the endometrium were not in the vagina and vice versa. Although in most patients, the vaginal and endometrial bacterial communities are closely related, different bacterial balance were detected in about 20% of the patients. So, current diagnosis of CE is traditionally based on histology, hysteroscopy, and microbiological culture. However, these three classical methods provide inconclusive or misleading results in 80% of cases. While histology usually underdiagnoses CE, hysteroscopy usually overdiagnoses of the disease, these methods cannot actually identify the pathogens causing the disease, and broad-spectrum antibiotics are often prescribed. Microbial culture is available to isolate the causative pathogen. However, between 20 and 16% of bacteria cannot be cultured in standard laboratory conditions, or are not usually assessed in clinical practice. Moreno reported in 2018, even when hysteroscopy and immunohistologically were used together, the correct diagnosis percentage was 55.5%. When the test results were consistent with all three tests, the correct diagnosis rate increased about 77%, but only 20% of the 65 cases were in agreement with the test result. In other words, it is difficult to evaluate the intrauterine environment by traditional testing alone. And even if problems are identified, the bacteria responsible are often not yet known, making it difficult to standardize treatment. EMA indicates the endometrial microbiome balance, providing information on the proportions of all endometrial bacteria, including those linked to higher pregnancy rates. EMA can determine the percentage of lactobacillus present in the endometrium, and it will determine whether the uterine microbial environment is optimal or not for embryo implantation. The endometrial biopsy must be taken from the uterine fundus using a people catheter. When taking the endometrium biopsy, it is very important to take the correct quantity of tissue, around 70 milligrams, which correspond to tissue with size of approximately 7 millimeters. Ensure that the sample is made up of endometrium tissue, not solely blood or mucus. To perform the EMA or ARIS tests, antibiotic intake should be avoided at least 7 days prior to taking the sample. The endometrial biopsy recommended it should be taken between days 15 to 25 of the natural cycle. EMA also includes ALICE, which detects pathogenic bacteria that can cause chronic endometritis. ALICE also uses NGS technology to provide microbiome information in endometrium tissue by analyzing the abundance of specific bacteria causing chronic endometritis. Specific bacteria include Escherichia, Klebsiella, Staphylococcus, Streptococcus, Enterococcus, Neisseria, Chlamydia, Leplasma, Mycoplasma. The result presented 6 patterns. Classification of the endometrial microbiota profile: normal is high percentage lactobacillus. Abnormal is significant presence of pathogenic or dysbiotic bacteria. Dysbiotic, low percentage lactobacillus. For ultra-low biomas, the amount of endometrial flora is extremely low. Suggested probiotic and antibiotic therapy. Recommendation for antibiotic therapy will always be guided by an expert clinical microbiologist. EMA include ALICE, the result of C diagnosis, and abundance of C-causing bacteria are also shown in the EMA report. If the endometrium is non-lactobacillus dominated, the report will suggest adequate treatment for each patient. If the ALICE test is positive, the report will focus on the detection of the specific bacteria causing chronic endometritis, so the suggested antibiotics is a different pattern between the result pattern 2 and 3. In probiotic treatment, vaginal treatment is recommended. These drugs are available in Asian countries as vaginal administration. These capsules are packed with lactobacillus in balloons and are administered from the 4th or 5th day of menstruation. In bag, lactoflora differs in some of the species of lactobacillus packed in these capsules. Different patients are more likely to colonize different species of lactobacillus. So, if one species is not effective enough, a change in the type of lactobacillus may be an option. Lactoferrin is not a bacteria and does not directly increase lactobacillus. Also, lactoferrin is taken internally. It is not unclear after an endometrium, and the evidence of this is currently unclear. Treatment for chronic endometritis has also been reported for about 10 years. Many previous reports have recommended doxycycline or a combination of ciprofloxacin and metronidazole. Doxycycline is a broad-spectrum, powerful antimicrobiological agent and should not be used extensively in cases where the causative bacteria is unknown. And ciprofloxacin should not only be used for Pseudomonas aeruginosa. We urgently need to change the way it prescribes and uses antibiotics. So, because antibiotics is one of the biggest threats to global health, food security, and development today, misuse and overuse of antibiotics in humans and animals are accelerating the process. If antibiotic resistance becomes more serious, there will be no more effective antibiotics for many different infectious diseases. If chronic endometritis is caused by some kinds of bacteria, then identifying the causing bacteria is essential for treatment. The world urgently needs to change the way it prescribes and uses antibiotics. 2 questions. With this background, we designed a study to investigate the 2 hypotheses shown here. It is possible to improve the outcome of ART by probiotic treatment based on the result of EMA and ALICE. And 2, can we avoid to use broad-spectrum and powerful antibiotics resulting in antibiotics resistance? So this is the prospective cohort study at Single Fertility Center from July in 2018 to March 2020. A total of 155 women younger than 43 years old who continued to undergo IVF-ET treatment were enrolled. Recurrent implantation failure was defined as a failure of at least 3 previous ET attempts. Patients had untreated tubal factor were excluded. We suggested MR and RS for the rest patients and confirmed whether patients described tests or not. Written informed consent was obtained from all patients prior to join the study. For patients who wanted to undergo MR and RS, endometrial tissue was obtained by aspiration using a PPL catheter on 15 to 25 days of menstrual cycle and diagnosed of microbiome by NGS. The patients were treated following the description specified in MRS reports, antibiotic treatments, and probiotic treatment for the vagina. Primary outcome measure is cumulative pregnancy rate of 2 additional ET after they were suggested tests. Statistical analysis was used on pair t-test and chi-square contingency, and the statistical significance was determined in p-value under 0.05. Patient characteristics such as age, body mass index, duration of infertility, and the history of miscarriage were comparable between the groups. The mean number of unsuccessful implantation was more than 5 cycles in each group. And this is flowchart. Among all patients suggested MR and RS, 107 patients wished to undergo these tests. The other 51 patients didn't want to do these tests. The recommended therapy for mild or ultra-low was probiotics treatment using vaginal capsule, including Lactobacillus. And patients with abnormal result in MR had antibiotics corresponding to the detected bacteria as well as probiotic treatment. We compared ongoing pregnancy outcome between these groups. According to the result of MR, 49% of patients had normal microbiota. Patients with mild and ultra-low results suggested intravaginal administration of Lactobacillus product as recommended treatment. Abnormal microbiota was detected 21% of patients in MR, and among this group, RS detected significant amounts of pathogenic bacteria in 8 patients. These results show the detected bacteria from patients with an abnormal result. The most detected bacteria of the patients with abnormal in MR was Gardnerella and Bifidobacterium. These bacteria might disturb endometrial microbiota. That's why the percentage of Lactobacillus was very low. The most detected bacteria of RS-positive patients were Streptococcus and Staphylococcus, suggesting that these bacteria may be associated with chronic endometritis in real patients. These results are similar to bacterial composition reported by Moreno in 2016. From those results, suggested therapy were mostly amoxicillin and clavulanic acid or metronidazole. Antibiotics were not required, and probiotic treatment alone was recommended treatment in 8% of cases. When patients had predominantly Bifidobacterium, then no antibiotics are recommended for treatment. Bifidobacterium is often detected as a constituent bacterium in specimens from patients with abnormal and microdysbiotic diseases. Bifidobacterium are considered to be beneficial in the intestinal environment, but in the uterus they do not have an moderately function like Lactobacillus, and the environment in which bifidobacterium is predominant may not be appropriate intrauterine environment in terms of implantation. In a hospital, there were some cases of pregnancy in rape patients when the bifidobacterium-dominated environment was changed to a lactobacillus-dominated environment by provided treatment. Here is the percentage of lactobacillus among the patients with abnormal result. Almost patients had a decrease in the percentage of lactobacillus less than 60%. The number of patients with lactobacillus reduced to less than 10% amounted to more than 40%. The endometrial microbiota had been replaced in bad bacteria. 60 patients who had abnormal result underwent second biopsy after recommended therapy. 12 patients improved their intrauterine environment after the initial treatment. The remaining 4 patients needed the third biopsy. 2 patients were recommended amoxicillin and carbonic acid, and the other 2 were recommended for initial treatment with metronidazole. However, the environment did not improve by the first recommended therapies, so 2 patients treated with amoxicillin and carbonic acid needed additional treatment using metronidazole, and the other 2 had additional treatment with clindamycin. They improved their microbiota after additional treatment. We defined cumulative pregnancy rate as the fertility outcome with 2 additional ET. The difference of the clinical pregnancy rate was significantly higher in the study group than in the control group. Before EMA or ARIS were tested, the patient who did not succeed in FET more than 5 cycles after these tests, about 65% of patients got clinical pregnancy just in 2 additional FET cycles. Also, the difference in the ongoing pregnancy rate was statistically higher in the study group. About 55% of the patients who underwent EMA and ARIS succeeded in ongoing pregnancy during a very short period. This is a pregnancy outcome of frozen thawed embryo transfer. There was no difference between the transferred embryos between 2 groups. Single egg transfer was done about 60% of the patients in both groups. As a result, the group examined for EMA or ARIS had significantly better pregnancy rates. This is limitation. The lack of randomization, although it is prospective, PGTA was not performed in this study. During this study period, PGTA was not permitted by the OBGYN Society in Japan. Further prospective studies are needed to confirm the efficacy of EMA and ARIS. With NGS technology, this biosis microbiota was found in more than half of the recruited patients. Personalized treatment recommendations based on EMA and ARIS results can improve IVF outcome of rape and repeated pregnancy loss. From previous reports, doxycycline, a broad-spectrum antibiotic, is often used to treat chronic endometritis. However, there was no cases that the suggested treatment was broad-spectrum powerful antibiotics during this trial. And the lactobacillus may also be the target of some antibiotics, so appropriate administration of antibiotics for the target bacteria is critical, and broad-spectrum antibiotic may not be restrained, reducing the physical and economic burden on patients. We proceeded to the multi-center study of EMA and ARIS. In this study, the efficacy evaluation of EMA and ARIS will be performed with the Japanese Institution for Standardizing Assisted Reproductive Technology, JISART. Criteria as shown here Inclusion criteria: patients undergoing a treatment registered at registered institutions with scheduled embryo implantation, patients who can perform re-examination if necessary, and age 20 to 43 years old. Exclusion criteria shown here. At this time in progress, 13 centers have participated in this study, and 426 patients have been tested already. There were 241 patients with a reported prognosis of pregnancy. The result of the multi-center study was similar to our result in the first part of this presentation. So, antibiotic therapy was recommended in only about 24% of all patients. These results suggest that antibiotics are not necessarily essential for all patients to maintain lactobacillus-dominated intrauterine environment. On the other hand, the percentage of MO result as ultra-low differs considerably between centers. In hospital where antibiotic administered habitually or unconsciously before and after the examinations or during the transplantation cycle, more than 70% of the patients were found to be ultra-low. And there are concerns that overdose or inappropriate administration of antibiotics may have led to the disappearance of even Lactobacillus species. In another case, MO results were also ultra-low in patients who were diagnosed with chronic endometritis according to histologically using CD138 and was frequently treated with multiple antibiotics. Broad-spectrum powerful antibiotics can even eliminate lactobacillus. Considering the effects of chromosomal abnormalities on the pregnancy rate because of the lack of the PGT of all embryos, we focused on the clinical course of patients under the age of 37 years old from among those with submitted pregnancy outcomes. The more lactobacillus in the uterus, the higher ongoing pregnancy rate. Conversely, the more bad bacteria other than lactobacillus, the more miscarriage rate were higher. This result suggests that a lactobacillus-dominated intrauterine environment may be necessary for continued pregnancy. From these results, Emma and Alice can be beneficial for patients with a history of or recurrent pregnancy loss because chronic endometritis has been linked to these events. Assessing the microbiological environment and the treatment based on each person's environment could make the appropriate endometrium for the embryo transplantation and growing. To avoid the abuse of antibiotics, it is important to accurately identify the bacteria present in the uterus. If some bacteria are present that are making the uterine environment worse, individual treatment for the causative bacteria may improve pregnancy rates and reduce the burden on the patient. Acknowledgements from here. Thank you for listening.
Okay, thank you very much, Dr. Iwami. We have a question from Japan that the question is about Emma. If Emma show Lactobacillus is low and Alice show the presence of some pathogens, can the patient start to take probiotics and antibiotics at the same time? What is the right process of the treatment? Can you explain, please?
The report suggests some antibiotics. The patient take firstly antibiotics and the proceeding probiotic treatment is better.
I see. So you mean we should treat the patient with antibiotics first and then probiotics, right? Okay, thank you.
Yeah.
We have quite a few questions coming up. Another question is, how long should probiotics be treated before the ET, the embryo transfer?
We usually use probiotic treatment using Imbag and Lactoflora. Usually Imbag 7 days in per packed. So 7 days use before ET, and Lactoflora packed one package, so 10 days used before ET.
Okay, thank you. There's another question. I think this is a doctor from Taiwan is asking that, is there any evidence in the literature showing oral or vaginal probiotics can change the environment of the uterus or endometrium?
The several reports showed vagina and microbiota closely related. 80% of patients same bacteria in vagina and uterus. So we usually use probiotic treatment from 4th to 5th days of menstruation. That means end of the menstruation, vagina and uterus transport some good bacteria like Lactobacillus. We think so.
I see. So you mean the Lactobacillus can be increased by vaginal probiotics because the vagina and endometrium is connected. So the vaginal probiotics can increase the Lactobacillus in the endometrium, right? And how about oral probiotics? Do you think oral probiotics can also help the endometrial Lactobacillus?
We only use Imbag and Lactobacillus. So I don't know. We don't know all of the vaginal capsule, including Lactobacillus, is effective or not. However, we do not recommend lactoferrin in taking orally. It's change the bacteria in the intestine. However, probiotic treatment by vagina, including Lactobacillus, maybe almost packet, almost unit concentrate Lactobacillus to uterus.
Okay, thank you. And another question is, do you use for endometritis, do you also use hysteroscope for the diagnostics? And how do you combine both, or you choose the method to diagnose the endometritis between hysteroscope and ALICE?
We usually test hysteroscopy all patients before first cycle, and the reason why hysteroscopy finding the endometrial polyp or submucosal myoma is effective by using hysteroscopy. However, at our clinic, in other study, we diagnosed micropolyp or edema. It's not connect MR or RS result. Some patients had a lot of micropolyp and edema. However, MR and RS normal result. So we usually trust the MR RS result if patients had many micropolyp or edema using hysteroscopy. So we use hysteroscopy to find endometrial polyp or myoma.
Okay, thank you. We have another 2 questions, but I think Dr. Iwami already answered. Let me repeat this. The first question is, what is the better outcome using vaginal probiotics drug or oral probiotics drug? And Dr. Iwami has answered that she hasn't used any oral probiotics before, but vaginal probiotics showed effective. And the second question is, what do you think about taking lactoferrin can increase the probiotics on endometrium or not? And Dr. Iwami has answered that she does not suggest to take lactoferrin because it doesn't go to endometrium directly. Okay. Okay, maybe I think we have only a few minutes left. Maybe there's another, I think we can go to the last question. Can you share some of your experience after vaginal probiotic treatment? How many % of the people showed an increased lactobacillus in the endometrium?
Our study, 16 patients with abnormal result with MR. 50 patients increased lactobacillus in the uterus. So that means over 90% of patients increase lactobacillus after MR test and suggested therapy. Over 90%.
And do you see any difference between among all these people, the patients? They have different speed of the increasing lactobacillus in the endometrium.
Everyone increased. However, the low percentage of lactobacillus, more longer duration increasing lactobacillus, lower and lower, the more longer and longer duration needed. So the patients 0% to between 10% lactobacillus at the first examination in MR. These patients needed to second therapy. So one first therapy and probiotics treatment, second biopsy, second suggested therapy, and probiotic treatment increase. So it depends on the percentage of lactobacillus first test, we think.
I see. So you mean if the patient has very low lactobacillus in the endometrium, it takes more time for the treatment, right?
Yes,
Okay.
I think so.
Okay, I think we have covered all the questions. Thank you very much, Dr. Iwami, and thank you very much for your excellent speech. Thank you very much. Thank you.
Thank you very much.